Evening and welcome to Connecticut United Ways virtual Alice Town Hall on the cost of healthcare. My name is Lisa Tepper Bates, and I'm the President and CEO of United Way of Connecticut. In early September, Connecticut United Ways released the 2020 Alice Report, the fourth Alice Report for the state of Connecticut, a report on families who are asset limited, income constrained, and employed. The 2020 Alice Report revealed that even before the onset of the COVID-19 pandemic, fully 38% of Connecticut households were walking a financial tightrope and struggling to make ends meet. When we talk about Alice, it's important to recognize that we all know Alice. Alice is the essential healthcare worker caring for aging parents at home and for COVID patients in our hospitals. Alice is the teaching assistant who helped our children adapt to virtual learning, or the bus driver who gets our kids to school. Alice fixes our cars and works in our local shops and restaurants. Alice is our friend, neighbor, coworker, and family member. We and our economy lean on Alice for support in a number of ways. Yet right now, Alice households are struggling to feed their families, access affordable childcare, maintain their housing, and ensure their medical care. The focus of our Alice Town Hall this evening is on this last category of healthcare. Over the past 15 years, families in Connecticut saw the cost of healthcare rise by 77%, while median wages only went up by 21%. According to the State of Connecticut Office of Health Strategy, the average family could buy a car for what they spend on their health insurance coverage in just 1 year. Data from the Healthcare Cost Institute's Healthcare Cost and Utilization Report shows that between 2014 and 2018, healthcare prices increased by 14.9%, while utilization increased by only 2.5%. This signals that, despite paying higher premiums, many families simply cannot afford to use their insurance due to high deductibles, out-of-pocket costs, transportation barriers, which limit access or the inability to take time off from work or secure childcare so that they can access the care they need. From Connecticut United Way's 2020 Alice Report, we know that more than 50% of workers in Connecticut are paid hourly. And we know that these hourly workers, in particular, those who work on demand or gig workers and contingent workers, are less likely to receive benefits such as health insurance, paid time off, family leave, or retirement contributions through their employer. We also know that being asset limited, lacking any substantial savings, is a defining characteristic of our Alice demographic. Economic stability is a key social determinant of health, and simply put, a lack of economic stability means that families don't earn enough to afford the things that they need to stay healthy, both physically and mentally. Further, more than 1/3 of Connecticut households are without any financial cushion and do not have enough income to cover current expenses, let alone the costs that often accompany unexpected health emergencies. This vulnerability means that an illness or injury can send an Alice household spiraling into poverty. And while all this was quite clear to us before the COVID-19 pandemic, the public health emergency has only served to underscore how crucially important it is for Connecticut residents to have access to the health care they need. Connecticut United Ways are thrilled to bring together tonight 3 subject matter experts to provide their perspectives on access to healthcare, the cost of healthcare in Connecticut, social determinants of health, and the need to address health disparities across our state. Our panel this evening includes Dr. Setu Vora, Chief Medical Officer of the Mashantucket Pequot Tribal Nation, Karen Siegel, Director of Policy, Health Equity Solutions, and Rafael Perez Escamilla, who is a professor of public health, Director of the Office of Public Health Practice, and Director of the Global Health Concentration at the Yale School of Public Health. I'm grateful to Dr. Perez Escamilla who will also serve as our moderator for the event tonight. Thank you to all of our panelists, and thank you to all of you who are making time tonight for this important discussion so that we can all better think together about how to create stability for ALICE families in Connecticut.
Thank you, Lisa, and hello, everyone. I hope you can hear me well. My name is Rafael Perez Escamilla, and Health. I have the distinct honor of moderating this evening's virtual town hall. First, I would like to introduce this evening's esteemed panelists. Let's put some faces to their names. First, please welcome Dr. Setu Vora, Chief Medical Officer at the Mashantucket Karen Siegel, Director of Policy at Health Equity Solutions. Hello, Mrs. Siegel.
Hello, and good evening, everyone. Thanks so much for having me.
Thank you all for leading today's conversation surrounding a major trend of the 2020 Connecticut United Ways ALICE report, which is the cost of health. And of course, you are invited to submit questions for our Q&A portion of the program. And without any further ado, I would like to make some initial statements about why, in my mind, affordable healthcare is so important. You may hear us say ALICE several times. Assets, limited income constrained, employed. Despite working hard and often working multiple jobs, ALICE households struggle to make ends meet. ALICE families have to make incredibly difficult decisions every day as they balance their household budgets. The ALICE report is a financial so important. I encourage you to visit alice.cityunitedway.org to download a copy of this year's report. According to the ALICE report, statewide, 38% of families fall below the ALICE threshold. That's nearly 4 out of every 10 households. On demographic, environmental, and socioeconomic factors will continue to grow if we don't act. Volatility in health insurance availability and coverage, increasing out-of-pocket costs, even for those with employer-sponsored programs, which is quite alarming, and shortages of healthcare are seeing under the conditions of the current COVID-19 public health emergency will continue to impact ALICE households disproportionately. Across Connecticut, the increasing impact of these incidents from either severe weather or pandemics is felt most acutely by ALICE families and their surrounding communities. during a public health crisis. Financial instability will mean additional costs for Alice households. Skimping on essentials, from food to healthcare, leads to greater long-term problems. And while these are not new issues, of course, they have only been exacerbated with the onset and deep advance from our esteemed panelists. Mrs. Siegel, how do unplanned expenses, such as medical bills, impact an Alice household's budget?
Thanks for the question. As someone who's lived on a constrained income myself, I know well that any unplanned expense means making sacrifices. And while I certainly have been fortunate enough, our systems are structured and the limited opportunities for acquiring assets and the limitations on intergenerational wealth, this kind of impossible choice really disproportionately affects Black, Indigenous, Latino, and other people of color in our state.
And speaking about these impossible choices, Dr. Bora, can you please share with us how are most Connecticut residents dealing with healthcare debt in general?
Yeah, thank you for that question. Certainly, most folks who are employed and they have some form of health insurance or health benefit coverage through an employer-sponsored health plan, especially if they have a high deductible type health plan, which more and more seems to be the case. Oftentimes they try not to even incur the debt in the first place. So we see a trend where some folks may actually forego some necessary medical care or testing as well, especially in light of what they may face in terms of a bill. But many a times when they do have to undergo a major testing or a procedure, or for example, let's take the case of Emily. Let's say Emily just got diagnosed with rheumatoid arthritis. And now her rheumatologist, her doctor, prescribes her with a special medication called Humira injectable. And that medication really helps control the rheumatoid arthritis. The person needs it, Emily needs it, but the cost of care for a year's worth of treatment for Humira could be $70,000. And so certainly there's an out-of-pocket expense associated with that expensive treatment. And oftentimes patients have to decide, do they want to incur that? They start rationing their own care, delaying time between treatment. Certainly, they may start out with just borrowing money from their own credit line, tapping their own saving bank if they have some money squared away, that many families don't, as we all know it. And then they end up relying on family and friends. I'm sure many of the viewers might know of this simple, painful statistic that almost 1/3 of GoFundMe accounts are to raise charity crowdsourcing money for healthcare expenses. Now that's an incredible, powerful, painful statistics in a wonderful nation such as the United States. So people try all sorts of different things to just make ends meet, to make their medical bills. And we see that being played out, resulting in some cases in personal bankruptcies. By some account, almost 70% of bankruptcies in the US are related to medical issues, either because people just cannot afford the cost of care, or they have to stop working because they just can't due to their disastrous illness. So we see that being played out throughout Connecticut as well.
Thank you very much, Dr. Vora and Mrs. Siegel. And your responses really illustrate also the fact that we live under an extremely expensive tertiary care healthcare system predominantly, and that without shifting priorities and investing much more in primary prevention, in health promotion, in people having access to adequate healthcare screening food security, and of course, all sorts of other securities that human beings need to be able to be healthy mentally and physically, it is going to be very difficult for me to see how we could get out of this major crisis of living in a country which happens to be the richest in the world, but has one of the most unaffordable systems in the world at the same time, and I would say inefficient as well. So taking a deeper dive at current resources and needs in Connecticut, Dr. Bora, have you seen an impact on mental health of Alice families due to exacerbated stress caused by the pandemic?
Certainly, I see it in my own household. I see it in my family and friends. The deep sense of social isolation, which was prompted by appropriate non-pharmaceutical intervention required to reduce the spread of the virus. But that results in significant worsening of people's pre-existing depression, anxiety. We see cases of eating disorders becoming worse. Oftentimes, many people who do suffer from substance use disorder, again, notice that their use of substances goes up significantly during these stressful times. Some of the constituents that we all work with report increased prevalence of violence, intimate partner violence, domestic violence. Um, and frankly, the kids are suffering as well because of disruption in their routine schedule, loss of their social contacts, lack of sports that provide some structure, and in many cases, secure food, because many kids rely on school meal program to really have their nutritional intake met. So you're absolutely right. This is not just a viral disease pandemic. The second tsunami is that of the accompanying mental health disorders that are starting out new or worsening when they were pre-existing before.
Yes, no, what a most relevant answer, the one that you have just provided. And indeed, in these days and time, we call what you just described not only a pandemic, but a syndemic, because here you have a situation where a public health emergency, a global pandemic such as COVID-19, is exacerbating not only health insecurities, but also food insecurity, and is also affecting much more people who have overweight, obesity, type 2 diabetes, hypertension, and so on. So this, we hope, is a wake-up call for all of us in Connecticut, the country, and the world, that this is not the time to think about compartmentalizing the solutions. This is going to really require a whole systems approach, where hopefully we will start seeing much better coordination between the social services sector, the healthcare sector, and other sectors that are really crucial for people to have not only healthy bodies, but healthy minds as well. So, Mrs. Siegel, do you believe there is an opportunity for a larger policy-driven investment for parity in health resources, including medical, dental, mental, and other health?
Yes, I think there are several opportunities, but I think we need some context to understand how we think about what the solutions are. And the way we think about that at Health Equity Solutions is that structural racism is really the root cause of the deep and persistent inequities in health, and also in the distribution of resources that limit people's opportunities to be healthy. So we need to carefully examine our status quo for opportunities to intentionally dismantle the racism that's so pervasive that we often don't even see it. And that includes focusing on, to build on things that both of you have said, focusing on investing in community-based services, collecting race, ethnicity, and language data so that we can check the assumptions we're making and really measure our progress, make sure that we're reaching everyone and not just some communities. Engaging and listening to the people who experience disparities, and making sure that we're meeting people where they live, work, pray, and play so that we can support them in ways that's culturally and linguistically appropriate. For example, through community health workers who can often help people overcome barriers to health. People who look like them and speak their language and can offer that kind of advice. And I think that in order to reach structural change, we really need to get our health systems to a place where we can stop calling people non-compliant or blaming people for their conditions or circumstances and asking, what do you need and what's not working? I think that's the beginning for how we get to parity in all of these resources.
Yeah, and your response is, which is so thoughtful, so insightful, thank you very much, also reminds me of the ongoing situation where we keep on seeing headline news that low-income ethnic racial minority groups are hesitant to take the vaccine because they are afraid of it, because they don't think the vaccine is going to work on them and things like that. When in fact, the most recent research, what is showing is that in that sense, they are not more hesitant than any other group, including whites in the US population. What they are really going through is they are very reluctant to even try to make an appointment, because given their discrimination and racism experiences that every day they have to go through, tells them, don't even try. You are not going to be prioritized. You're not going to go first. It's going to be almost impossible for you to be able to get an appointment. And even if you get one, you may not be treated the way you like. So it's incredibly important that we also stop stigmatizing groups, not because they are poor or they belong to certain ethnic racial groups. It means that they are less likely to understand, or that they're less likely to want their benefits, their families to benefit from the public health and medical knowledge that immense one that society has now. So I'm hoping when we get to the action discussions that we can go back and revisit this point as to, how we can all think about collectively addressing structural racism, as well as intentional or even unintentional racial discrimination. At the end of the day, it doesn't matter if it's intentional or not. It harms the psyche, it harms the minds, and it harms the arteries and the overall physical well-being of people. So that needs to stop as part of our renewed efforts to come up with a more affordable, equitable healthcare system that is offered with good quality for all. So thank you so much, Dr. Bora and Mrs. Siegel, for your reflections on what we have and what we need to do more in Connecticut to make this happen.
I'll just make a quick
sure, please,
comment to what we heard from Karen. You brought up the question around labeling people with non-compliance type labels, right? And I think it's almost that we have to start perhaps looking at that with the same lens of high reliability or patient safety that we are all learning, which is to see an individual failure almost as a symptom. And the real root cause is to ask the 5 whys. Why did that person not show up for the appointment? And then dig deeper to uncover the systemic failure mode that allows that individual failure mode to happen in the first place. So it'll require a redesign of our thinking and how we structure our own systems.
Absolutely. This is totally not at all shaming individuals, but it is about shaming systems. It's about shaming all of us as a whole of society for have allowed groups of people to have gone through the major unjust and inequitable experiences that historically, for centuries, many of them have had to go through. So I guess we're all reaching consensus here that no matter which road or roads we choose to follow, if we don't intentionally beforehand seek that whatever efforts we put into place are accountable to equity and social justice and anti-racism outcomes, it is unlikely that we will be able to change the very dire situation on lack of affordable care that is being reported for our or all the citizens or people living in the state of Connecticut. Very good. So then let's move on to talk about the Alice experience itself. So Karen, what do you predict about the future of Alice families' healthcare costs? How does it look like in your mind? And can we discuss about, is it going, these costs to go up? Is it going to go down? Is it going to stay the same? Where are we heading in these crazy times?
Well, I think it would be pretty naive of me to suggest that I think healthcare is going to become affordable very quickly. I do see a lot of hope in the current proposals and the current ways that we're seeing policy change around healthcare costs. We did a series of listening sessions at HES in 2020 to ask people what affordability meant to them. And it was very clear that reducing premium costs alone wasn't going to address affordability for most of the people we spoke with, and especially for people of color in our state who, again, are subject to economic inequities, increased health risks resulting from systemic racism, and all kinds of other barriers. Premium support will definitely mean that more people are insured, and that is a good thing. But in order to be able to actually use that insurance, it needs a couple of things. It needs to be comprehensive. So it has to cover mental health and oral health and not just the basic physical health. All of those things are important. And it needs to have an adequate network of providers so that people can get appointments. And then the second big piece of that is that out-of-pocket costs, particularly for people in the Alice households and in those income ranges, must be dramatically reduced. So that's part of why we have been supporting increasing the reach of Medicaid, because it's both a comprehensive source of health insurance and no out-of-pocket costs to people. So it really does facilitate access to care. So I think, we are making progress, but we have a long way to go.
Absolutely. And, you brought up as well the issue about out-of-pocket expenses, about deductibles. Our own son has a $6,000 deductible, and he's a preschool teacher. It's just it's just unfathomable. How can you call people having health insurance when you have those deductibles that essentially would drain the savings of most people in the country if they have any, just two or three visits to the doctor. And as Dr. Bora mentioned, then people choose not to go on time, and they end up in the emergency room, and the healthcare costs go up exponentially through the system. And of course, it ends up being reflected at the end of the day on even higher costs for consumers, for the individuals who are seeking that health insurance or access to health security. So, Dr. Bora, speaking about these issues on out of control costs and really, the inability for Alice and in many non-Alice families as well to not be able to afford the deductibles, the cost of insurance, and so on. What could Connecticut do about containing these costs, and how could we have a more fair governance oversight system of how these healthcare costs are being estimated and applied to different consumers?
Yeah, certainly. I think, instead of necessarily ascribing or putting blame on individual key stakeholders in the entire healthcare ecosystem that includes the patients or the families, the physician and other providers, the hospital systems, the layers of insurance payers, certainly the carriers, pharmacy manufacturers, the PBM that manage the pharmacy benefit. It is a very complex healthcare system. That's we all realize is the legacy of post-World War II. The employer-sponsored work-associated health plan benefit is certainly, a challenge for us. So instead of pointing fingers and assigning blame, the system is designed to really be excellent at sick care. As you rightly pointed out, it's not designed towards prevention. As a system, we incentivize procedures and expensive tertiary treatment, and we don't necessarily put investment or incentivize primary prevention. So what do we expect the system to deliver, right? So I think as citizens of Connecticut, first step would be for us all to realize the systemic factors that result in these outcomes: higher cost of care and inequities that are worsened even more. So to your question around what can we do about healthcare costs, certainly engaging in dialogue with all the parties. Certainly, I think the healthcare systems are going to be part of the solution. I think they are making attempts to move towards more value-based care as opposed to more volume. At the same time, there needs to be certainty in the marketplace as well, so that all of us can agree on one thing. Out of $4 trillion that go towards healthcare medical expenses every year in the US, by some accounts, 25%, $1 trillion is essentially waste. It does not add any value to improving the life quality outcomes at all. It is just inappropriate overdiagnosis, overutilization, unnecessary treatments. And that's unfortunately the waste in the system. Even if we start with identifying and reducing that, then itself can lead to a long way towards saving. And then we all perhaps would dig deeper into agreed upon transparency around what is the true cost of care. How may we share information with our healthcare consumers so that they know what to expect? I mean, there are not too many industries where you could go and, for example, would we ever go and buy an equipment from Best Buy or go to an auto dealer and buy a new car without even knowing what the true cost will be? Why is healthcare so opaque? And it's partly because of how it is structured in the current system. So I think the current stakeholders in the system also want to make a change. And the movement towards embracing radical transparency will lead to all the healthcare systems competing on value and not necessarily on market share.
Thank you very much. And this is a perfect segue for the last theme that we're going to address before we go into question and answers from the public. Because you have already mentioned the great importance of civil society to organize itself, to receive more information, to better understand what is driving these costs, who are the key players, where are the inequities, and how can change happen, through legislation, through policies, but also through what my dear colleague Kelly Brownell would call the science of public anger. How can people really become so upset about this very unjust system that we have to actually decide that they are going to, not take matters into their own hands in any negative way, but really in terms of electing officials and representatives who are actually going to work towards this goal of having a more just and transparent healthcare system that is affordable for all Alice families and the rest of the people living in our country. So United Ways and other health and human service agencies are helping to impact one or more of the social determinants of health, as all of us know here. It's a wonderful organization. But Dr. Bora, do you think this can be done at the individual level, or it's really an approach that is going to work if it's done at a systems population level?
Certainly, looking at the example of public health interventions in general, individual education, individual behavior change is necessary but not sufficient, as we all know. Unless there is an environment that facilitates those direction of change, there is going to be decision fatigue when it comes to just individual making choices for themselves and their families on a daily basis. So while it is certainly, we are all responsible and we want to do the right thing, and each person and families would perhaps certainly plan as best as they can to improve their own well-being and their own situation in life. At the same time, more investment made towards addressing unmet needs, social needs, which we know results in almost 80% or more of healthcare outcomes, right? I mean, it's shocking to me as a physician. Here I am trained in 4 different specialties to only then realize that collectively the contribution of healthcare industry towards the outcomes that mean to the patients and their families is only less than 20%. The rest is all social, systemic determinants of health. And we can call them social determinants of health, but essentially they're markers related to inequity and poverty. That's just a euphemistic way of saying that. Food insecurity is hunger. Unstable housing is homelessness. And so these are real pervasive problems within our state, within our towns, and perhaps the action could begin at the grassroots level around each neighborhood, gathering together, each town in its own spirit of self-governance, reinvesting attention and resources towards making sure that person who needs non-emergency medical transport for a dialysis run gets it. Why? Because it saves all of us money.
Mm-hmm.
Once we start reframing this redirection of resources towards unmet social needs as helping get return on health and demonstrating a return on investment, I think we'll see more action.
Yes, and I think the science totally supports the statement that you have made. So what we call in the US in academia human insecurities, the rest of the world calls human rights. And the UN Charter of Human Rights clearly spells out that all human rights are interconnected and are indivisible. So you cannot address in any efficient or effective way inequity, social injustice, poor health outcomes if the countries don't address all the human insecurities or human rights. So housing insecurity is an enormous driver of health insecurity. Health insecurity is also an enormous driver of food insecurity. And housing insecurity, food insecurity, health insecurity are major drivers of unstable issues in societies, including profound violence in communities that are affected by this lack of access to the most essential social determinants of health. And we also need to think about that public health and human rights are totally compatible with each other. And I think it's probably time, I don't know what Karen thinks, but it's probably time to really start advancing more the notion that public health means human rights, and addressing human rights requires addressing the social determinants of individual and public health. So, Karen, what can we do at the state level with regards to, coming up with more equitable and quite frankly effective solutions and cost-effective solutions that at the same time are fully aligned with respect for dignity and human rights? Specifically, what is Health Equity Solutions working on right now?
Well, the answer to that is a lot. We have a really ambitious policy agenda this year, because if now, as you were saying, if now isn't the moment to address these inequities and to really take steps to dismantle racism, then no moment will be the right one. We more specifically are working with partners on proposals to expand Medicaid eligibility, which I mentioned earlier. We're also working to improve and standardize the collection of race, ethnicity, and language data so that we can really look at how to address disparities and evaluate whether or not we're doing that. Creating a pathway to reimbursement for doulas, declaring racism a public health crisis at the state level and at the municipal level. Today, the 21st town joined in Connecticut, joined that movement with over 100 cities, towns, counties, and states nationwide. We'd like a state level declaration, and also working to implement a new commission to employ a health equity in all policies approach to state government. So if anyone is interested in any of those policies or learning more or wants to get involved, we're also co-hosting with partners the 3rd annual Health Equity Week starting on April 5th. There'll be a launch event where we'll talk about what's the policy pathway to equity for Connecticut, and then events throughout the week offering opportunities to learn more about some of these policies and hear from other groups about their work. And that my colleague is texting me to say that the blog page of our website has details if people want more information.
Yes, and I really encourage you to visit it. I greatly admire Health Equity Solutions, and among other things, until recently, they had their offices at the Hispanic Health Council building in Hartford, another wonderful agency with which I have partnered with for 30 years now. And several of our former MPH graduates really make all of us look good by having chosen to work for Equity Solutions. So the Yale School of Public Health is extremely grateful to your organization as well, Karen, in that regards. So I want to follow up, Karen. We have about 2 or 3 minutes more to follow up on this. And I wanted to ask you, in terms of Health Equity Solutions, do you also have partnerships, or how do you interact with those organizations that are trying to address equity from the education system point of view?
Yeah, that's a great question. So we have not done a lot of work on education specifically, but we have a lot of partnerships with grassroots organizations where we try to make sure that there are connections. In my personal life, I serve on the board of the Connecticut Association of School-Based Health Centers, and we have worked with them quite a bit. And we do education for healthcare providers. So we provide trainings and cultural humility training specifically, and also work with others who do that kind of work.
Yeah. Thank you very much. So we now have about 10 minutes for questions and answers from the public. And I don't know exactly how the forum organizers want to manage the Q&A session. So just let us know how myself and Karen and Dr. Vora can be useful for you at this time.
Oh, I'm seeing a question in the chat. I think this is directed to me. What could Connecticut do to make healthcare more affordable to those who have high deductible plans or purchase off the exchange? I think that's a great question. I think Connecticut's really well positioned to take action on that now. There were a number of premium subsidy proposals at the state government level this year. And because of the American Rescue Plan, which covers premium subsidies up to 100% for people in lower income ranges, now the state has the opportunity to take funding and use it either to cover cost sharing expenses for people on the exchange, which are for a family of 4 covering just 2 adults, is $5,000 out of pocket, so it's still quite high. And then the other option is to create a pathway to insurance for immigrants who are not eligible to purchase insurance and who also are not eligible to enroll in Medicaid. So that includes people without documentation, but it also includes folks who've been in the US less than 5 years and several other categories of immigrants who just have no access to health insurance.
Mhm.
Yeah, one quick follow-up comment to that. While the premium or subsidy support is helpful, I think perhaps also as a nation, we should focus on reducing the unnecessary utilization and the unit cost. Because even if we provide premium support and have people insured, so their out-of-pocket expense is low, but if the healthcare cost is still astronomically high as compared to any other OECD developed country in the Western European world, we all will ultimately pay in to that unsustainable growth in healthcare expense.
Mhm. Yeah. So I'll take this question because it's very dear to my heart. So how can healthcare delivery in other countries inform what we do to benefit the ALICE population? So the evidence is very clear that countries that practice the so-called socialized medicine, which is a very scary term for many who live in market-driven worlds. It's really a system that ensures as much as it can that no one is left behind. So countries like Norway, like Sweden, countries like Canada, countries like Costa Rica, for example, they make sure that the people living in the countries or their citizens have a universal access to high quality healthcare. It is somehow easier to do it through those type of systems because they do have national healthcare systems. The US is very, very challenging because we actually don't have for most part, a national healthcare system. I mean, we have some closed systems like the VA. We have some type of government insurance systems like, Medicare and so on. But for most part, I mean, we don't have like the public hospitals in the US that we see in many, many countries. So in France, for example, everybody goes with an ATM like a card, and they end up going to the doctor. The doctors run that card when they see the patients. The same procedure costs the same anywhere in the country with any doctor. It is much more affordable than in the US. And it is much more affordable than in the US. And at the end of the day, they have much more cost-effective results. They also invest much more in prevention, in health promotion, in primary health care. Some countries offer incentives to doctors based on how well they manage, the prevention of diseases versus just the tertiary care once almost catastrophic situations have happened. Some of the incentives include giving bonus points for those who choose to work with low-income populations. So at the end of the day, those systems require a social covenant. They require that people are willing to live in a country that most people will pay a much higher percentage of taxes than what we pay in the US, but they know that they're not going to have to worry for them or their families for healthcare for most part, for food security. They will not have to worry about quality education for their kids. So I would say that the most important lessons learned is that we do need to have much, much better federal coordination in the country. Healthcare systems, we have too many that they just don't communicate well with each other. We need much more representation of patients, of consumers, of community members at the tables where decisions are being made about the cost of insurance, about coverage, about the different options that can be considered. And I will rest my case by saying that we just saw in a matter of weeks how what was supposed to be the impossible task of rolling out the COVID-19 vaccines massively in the country changed only through two words: political will, and another two words, federal coordination. This is not going to work, I think, if everything is left to the states and to the towns to figure it out by themselves. And last but not least, we do have some positive aspects from some of our healthcare systems. We have many, and it's just like we have not learned enough from them. We have not done a systematic analysis of, okay, if we were going to take the best parts from the VA system, from the Kaiser healthcare system, from the Hartford healthcare system, and how would a fair, equitable, cost-effective healthcare system should look like 10 years from now. That would be my approach to this, and there are many learnings from other countries, some of which, by the way, have much less wealth than the US and much better healthcare outcomes. The maternal mortality among African American women is shameful. It is something that I just can't understand why there hasn't been much more public pressure to address it, because it's worse than many middle-income countries. And it's been going on for too long, and it is a very clear manifestation of, excuse the language, how screwed up our healthcare systems are.
And I think that's a nice or an appropriate segue to the question on how we can get clinical providers and institutions to invest in community clinical interventions, so that those community-based organizations can be sustainable. I think part of what drives maternal mortality and particularly racial disparities in maternal mortality is a lack of meeting people where they are before they're pregnant, recognizing that what we like to call hesitation, or what we like to assume is a distrust of health systems, is really rooted in recent history and in contemporary treatment. And that's why we're supporting Pathway to Reimbursement for doulas. It's why we have supported trying to foster a community health worker workforce that's more robust in the state, and encourage those relationships. And Dr. Vore, you were talking earlier about paying for value. One thing that's been done in other states is to require clinical providers to work with community-based organizations and lay health workers like doulas and community health workers.
Mm-hmm. And I just want to wrap up this amazing Q&A session by adding to what Karen just said, that in terms of how to make it sustainable, it has to be done through legislature. It has to be done through ensuring that there are reimbursable codes for community health workers, for the services of community health workers and other essential workers that very much are crucial for making the healthcare system properly work in the ALICE communities or the ALICE families. So thank you very much to our wonderful panelists. And this concludes the third in our fourth part of Connecticut United Ways ALICE Town Hall series, focusing on the cost of healthcare. Thank you again to our esteemed panelists who dove deeper into the data, shared resources available for families looking for assistance, and continue to advocate for the success of every child and every family in Connecticut. It is because of colleagues, of peers like them, that there is indeed a light at the end of the tunnel. And thank you to all who have turned in across the state. We know the cost of healthcare is top of mind as families navigate the economic consequences of the pandemic, and we hope you found today's discussion informative and inspiring as I did. I actually learned a lot from both Karen and Dr. Vora. United Ways in Connecticut are working on ensuring equitable outcomes for all. But as we learned today, there is much work ahead that needs to be done to ensure that every person in every community receives affordable, quality healthcare. If you or someone you know is searching for assistance, I encourage you to call United Way 2111 or visit 211connecticut.org. I'm sorry, it was United Way 211. Or visit 211ct.org for quick access to resources. 211 is made available to all Connecticut residents through a partnership between the state of Connecticut and Connecticut United Ways. If you or someone you know is interested in giving help, thank you in advance. I encourage you to contact your local United Way. You can show your support for Alice households by giving to your local United Way. United Way across the state are committed to ensuring every child, individual, and family has the opportunity to succeed. And this includes investing in programs, services, and initiatives related to affordable housing and homelessness, as well as COVID-19 response efforts. You can also get involved in virtual volunteer opportunities through the United Way in your community. We hope that you will help us spread the word about the 2020 Alice Report and the issues facing our state and communities. Be well, and thank you so much from Storrs, Connecticut, where I live, and it has been my pleasure being your host tonight. Have a very good evening.